Next, Peter McCollough is joined by Dr. Luigi DiBiase, clinical assistant professor at the University of Foggia in Italy. They cover ablation versus amiodarone for persistent atrial fibrillation in patients with congestive heart failure and an implanted device. Results from the AATAC trial.
Luigi, welcome to ACCEL.
Thank you very much.
Can you give us a little bit of background about why this trial was conducted?
Yes. So first of all, I would like to thank all the co-authors and the principal investigator of this trial, Dr. Andrea Natale. So as we all know, atrial fibrillation and the treatment of atrial fibrillation with ablation is successful and has been shown to be superior to antiarrhythmic drug treatment in many randomized trials. But when we look at the data, the number of patients that have been enrolled are with normal left ventricular ejection fraction. There are only a few studies that have been done with patients with reduced left ventricular ejection fraction. Therefore, we decided to conduct a study in a patient population where no data is available and where we are very limited with the number of antiarrhythmic drugs that can be given to these patients because of their abnormal LV function.
So these were patients who had heart failure with reduced ejection fraction, both ischemic and non-ischemic cardiomyopathy, who had an implanted device in, either an ICD or an ICT with a resynchronization therapy, and these individuals were in persistent atrial fibrillation.
Yes, had to develop atrial fibrillation and over time, and while developing atrial fibrillation over time, they had to be randomized to amiodarone treatment versus ablation. Of course, this study has been done because we do believe that keeping this patient in sinus rhythm is better than rate control.
Well, that's your belief system. Of course, you're an electrophysiologist and acknowledging those biases. So you did the right thing. You did a prospective randomized trial, multi-center. How many centers did you have and how many patients did you recruit?
203 patients from a multi-center study where the study was conducted between Europe and the United States of America with around 8 centers that included patients in this study.
Tell the listeners what approach the investigators took to the ablation therapy.
Yes, very important questions. The goal of the procedure was pulmonary vein isolation, as we have been learning over time from the beginning when Isaac Gare described the first triggering of pulmonary vein in the left atrium. But at the discretion of the operator, procedures could be done also more extensively to the pulmonary vein, including the posterior wall or the roof or the complex fractionated atrial electrogram. So I would say that it was a PVI plus, as we like to call these procedures in electrophysiology, although some operators felt better just to limit it to PVI alone, using radiofrequency energy.
It's my understanding that if the first attempt at ablation didn't work, that there were up to 3 attempts, and then after that point in time, there was a landmark by which the investigators started looking for atrial fibrillation as an outcome.
Yeah, actually, during the so-called blanking period, during the first 3 months, a second procedures could be done. And we have therefore presented the data that account for patients that have done 1 or 2 procedures as endpoint of the study.
Okay. And in the amiodarone group, how is the amiodarone prescribed?
The amiodarone was prescribed as a loading dose and then a maintenance dose, and it was, of course, prescribed in the standard of care way of dosages.
You had the advantage of everybody had a device in. All patients had an atrial lead and then a defibrillator lead. Some had left ventricular leads through the coronary sinus and the coronary veins for biventricular pacing. So in a sense, you had an implanted device doing surveillance for atrial fibrillation.
Yes, I think this is an important part of the study.
Patients, both arms had this blanking period for 3 months, and then the clock was started to look for atrial fibrillation. How did you define the primary endpoint of an atrial fibrillation recurrence?
Was the freedom from any atrial arrhythmia, atrial fibrillation, or atrial flutter, or atrial tachycardia lasting more than 30 seconds. This is the way we have defined that symptomatic or asymptomatic episode of any atrial tachyarrhythmias lasting longer than 30 seconds. That was our definition of recurrence.
And what were the principal results?
So the principal results was that the patient undergoing ablation after an average of 1.3 procedures had a higher success rate, around 70%, versus 34% of the patients that instead were randomized to the amiodarone arm.
So nearly twice as many patients were free of atrial fibrillation in follow-up. And what was that follow-up duration? How long?
The duration of the follow-up was 24 months.
Okay. And were there any confounders, do you think, that influenced results? Were the baseline characteristics and the other drugs the same?
There were no baseline characteristic differences between the two groups. What we found is that at a sub-analysis, patients that underwent PVI only alone versus patients that did PVI plus did worst. So limiting the ablation in this persistent patient to the pulmonary vein was giving to the patient a worse outcome than instead extending the procedures to a plus. Of course, the limitation of the study is that this plus was not completely well-defined and will require, of course, further investigation.
Now, were there any differences in clinical outcomes, such as rehospitalization, bleeding, etc.?
So we have this in the secondary point of the study where, patients that had no recurrence of atrial fibrillation improved their ejection fraction, their 6-minute walking test, and their Minnesota Living questionnaire. They reduced their overall rehospitalization for heart failure and for arrhythmia-related rehospitalization. And there was also a trend in reduced mortality.
Well, it sounds like a very strong positive step forward for the use of or attempt of radiofrequency ablation in patients with heart failure and a reduced ejection fraction who have a device in place that can help with monitoring. And in these patients, it appears as if radiofrequency ablation really results in a much larger fraction of patients who are free from atrial fibrillation and who could be managed over time, maybe more simply managed over time. Do you have any final important reflections on this trial, or what do you think the next steps will be for the research community?
Well, identification of an ablation technique and approach that would be widely available, since we found that more than PVIR is necessary in this patient population, is absolutely an important step looking forward. And another thing is just remember that ablation of atrial fibrillation in this more sicker population was done in this study by expert operators. So we need to allow every operator to increase their volume and their experience so that these results would be widely reproducible.
Well, I'll let that be the last word. And Luigi, thank you for joining us on ACCEL.
Thank you so much.